So the admin can configure the system with all the dependent variables. The admin can create users' accounts and manage users' accounts. The admin can also retrieve missing unique ID and update security information of clients on the system. The admin can supervise the screenings per site and export or download data based on some reporting indicators. And some of the data that can be downloaded by the admin is to get all the HIV screenings on a national level, to get all the tuberculosis screening, to get all the syphilis screenings, and to get all the other screenings recorded at the lab. Also, the admin can get ANC HIV screenings, and this gives them all the screenings recording for antenatal clients, and it also gives the gestation age at the time that screening was done. It does the same thing for syphilis, hepatitis, and other ANC screenings. And then it also gives a table of reports that can be exported for exposed infants HIV screenings. And it gives a table that can also be exported for exposed infants registration into care. Something that wasn't on the system yesterday that I had to add this morning is the self-test. And we have self-test kit distribution, condoms distribution. And because of that, I've added a new table or a new report where you can export the self-test results recorded on a national level. You can also export the self-test kit given from all sites. You can also export the number of condoms given on a national level. So this is the new addition to what we did yesterday. The administrator can also track screening history, pregnancy history, and address change history of any clients on the system. So now we'll move to today's agenda, which is looking at the screenings and management. Screenings and management is the second module of the system, and a user who is assigned the screenings and management role on account creation is welcome to the home page of the screenings and management module. This homepage holds a container with a blue header, and this container is only displayed for users who are assigned the pharmacy permission. It allows the pharmacists to be able to reassign themselves or assign themselves to the current pharmacy that they will be working from on the particular day. So this is applicable in countries where pharmacies rotate pharmacy, and since dispense and stocks are deducted from the current pharmacy, it is always accurate if the pharmacists always cross-check that they are in the correct pharmacy and that they are going to be deducting stock from the pharmacy where they currently are. If they make that mistake of dispensing from a different pharmacy, they will have to go through the process of deleting all of what they have done and doing it from their correct pharmacy. On the left side of the page, we have the pages menu. When you expand this menu, you will find a list of menus to other functionalities. The menu you will see here will vary from user to user, and it's going to be based on the permission you were assigned, and your permissions are based on your job function. So you hardly get one user who will have all of this displayed. Most of the time, especially for VCT providers and labs, you'll get general population counseling and testing. You'll get the referrals, and you'll get prevention and control. So what we are going to look at today is the general population counseling and testing, referrals, prevention and control. When you have a client who has been registered on the system, who is coming to your site either for the first time or has been a client at your site, You will expand this general population counseling and testing submenu of the pages menu, and then you'll find more menus under this. Because this client already has an account on the system, regardless of the site, as long as the account is within the same country, you skip create new client account and go to request release of client's file. You'll put the record access date as today. So this is, I want the system to release this client's file for me to use today. I'm going to use a client, SVG 1, 2, 3, 4. We're going to screen for HIV, but we're not going to screen. We'll just use this for demonstration. And I will submit. If you skip this step, the system is not going to release the file of this client for you to record or view any of the information you want. So this step is necessary. Now, two things about this step is that it helps the system log all of the files that you have accessed, and the supervisors will know who accessed what at what time. It also is a security function so that the system withdraws every file that was released at midnight. And so if you want this file on a new day, so let's say you release this file at 11:59 p.m. At 12 midnight, you will have to ask the system to release it again. So as long as the clock changes, the system will withdraw all of the files that was released for the day. And the time zone used is your current time zone. So it's going to work with your time. On this form, you are going to find that the system is telling you your current assigned testing site. If this is not correct, you want to call your supervisor and let them know that you have been reassigned to a different site and they will have to switch your site. Only pharmacists can change their pharmacy, but testers cannot change their site of test. Your supervisor will have to do that change for you. Once you are done and you have a success message, it means that the file has been released. You will come back to general population counseling and testing, and then you go to collect client information. You enter in the unique ID and click on collect information. The system is going to release the file of the client where we have previously recorded information for this client. As long as the account of the client was opened within your same country, the system will release the file for you. And on the file, it will tell you the site where the account was previously, the person who previously created the account here, and it will give you your current site. So any edits you make now is going to be tagged on your current site. But you can see the person who recorded or created the accounts the first time. On this page, we have two containers. The first container above here gives you prevention information. And this is very important when you want to do a prevention and control intervention. If you want to go with a risk reduction plan or contact tracing, you will use the information in this container. The container below holds all the tabs that you will need to collect data for this client. We have the first tab, which is the personal information. This gives you all the previously recorded information. If you want to review what is here and you want to find out if anything has changed, you can randomly ask the clients for all of this information on this form and ask them, your country of residence changed, is your address changed? So you will only edit the place. Let's say the address is changed now. You only edit the field that has changed. And then I will put in today's date, the date I'm making the change. And then I'll go to save. Once this is successfully updated, you will see that the address is updated here. So let's go through all the context of the personal information form. The date the account was created is time-stamped automatically. The person who created this client's account, the name of the person who is reporting the case, which is the person who is currently logged in, the address of the site, which is the site assigned to the person who is currently logged in. The date of report is the date that you're filling this form, either your current date, and for past record will be the date on that record. The client's information, the first name, middle name, last name, mother's maiden name, testing code, unique ID, and unique ID type are automatically filled from the information that you entered when the account was created. Now again, first name, middle name, last name are not required. It depends on the regulation in your country. If you are allowed to collect client's name, you will fill it in on account creation. If you are not allowed to collect name, just type in the first letter of each of the names. So if you're in a country where you are not supposed to collect the client's name and you're supposed to screen anonymously, so you want just the first letter of their first name, the first letter of their last name, the first letter of their mother's maiden name, and the unique ID. Either you're using a hospital registration number or you're making up an ID, but it must be unique to that client. And so what will show up here will be the first letters of the names you use on account creation. If the clients become positive and you feel and you want to put in the names, or the regulation does not stop you from putting in the names, then the supervisor is going to update these names. So names are not editable by anybody but the supervisors. So you can use the unique ID to retrieve the client's file and now update the names on the page of the client. So again, names are not required on the system. The name should be filled in based on what is allowed in your country. We have the ID type 1, ID type 2, ID type 3. So in countries where you have several types of ID, hospital registration numbers or social security number, or something that you use nationally, you might want to put in all of those IDs here so that in the event where the clients miss their unique ID or can't remember, you will have a second layer of ID where you can do a verification or switch their ID at some point. Also, the date of birth is not editable by anybody but the supervisor. So if there was a mistake entering this, only the supervisor can update this. The country of birth is always editable on this form only. The country of residence is always editable only on this form. The address in the country of residence is not required. Again, if you have any need to collect the address of the clients, you put it in here. The health district or the wellness center is going to be the health district where you are screening from, or the name of the health center. The parish will be the parish where the health district is located. The length of time in the country of screening. So if the client has been here for a short while or has never left this country, it might be equal to the current age. Or if the client says that they've been here for the last 10 years, you want to put 10 years. The biological sex of the clients was filled in at the time of account creation, and so only the supervisor can update that. Then you have the gender identity, which is what the client identifies as, and you can always update the previous entry. The sexual orientation of the client, you select from a list, a drop-down list of sexual orientations, and then the telephone number, which is not required. And if you have any need to collect this, then you fill it in here. The marital status of the client, the ethnicity, the occupation, the highest level of education, the number of sexual partners are all required field. So for all these required fields, if you do not know the answer or the client doesn't want to give the information, you want to select unknown as the option. If the client is a baby or a client that is not supposed to answer these questions, then it's not applicable. The types of sexual activity is going to be the sexual activity that the clients tell you that they use, right? And then if the client is currently pregnant for females, if not a female, then it's not applicable. Has the client's regular sexual partner been tested for HIV? Either you put yes, no, or none, or not applicable. Is the client alive or dead? So if you're filling in this form in the emergency room when somebody was brought in almost dead and the person later dies by the time the result returns, you might want to put in dead here and the cause of death. But if the person is in front of you, you don't need to ask this question. You put alive and the cause of death will be not applicable. If the person was dead, you put dead and the cause of death will either be HIV-related, HIV death, or unknown. Has the client left the country or reside elsewhere? You are going to answer if the client has ever lived somewhere else, or the client is not a current resident of the country, or the client is only here on a visit, or anything that makes the client have any dealings outside of your current country of screenings. You will put in the answer yes, no, unknown, or not applicable, and then you save. Once you are done with the personal information, you will move to the risk behaviors. Now, the risk behaviors have questions for reporting and is one of the most important form on this system. So you have to answer all the questions on this form. You fill in the date of report, which is going to be the current date if you are screening, if you are entering it live, and if you are screening or you're entering a past record, then you put in the date of the past record. Yes, someone raised hand.
Yes, to go back to the personal information page, just for clarity,
okay.
The length of time that the person is in the country, if they have not left the country, it must be equivalent to the person's number of years. Is that correct? The age.
So if that's, yes, exactly. So if they say that they've never left the country, so their length of time in the country should be equal to their age.
Okay, next question. For sexual orientation, that can be edited, it can be changed?
Yeah, you can always edit sexual orientation. So every time they come for subsequent visits, if their sexual orientation changes, you can always update it.
Thank you.
But what you have on this form is always the most recent entry. When you go to history of the clients, that's when you find all the previous entries.
Okay, thanks.
Okay. So on the risk behavior forms, you want to collect information of the behaviors that put the client at risk of having any STDs, or that put the client, or that flags the risks that actually contributed to why the client is positive or has any STD. So we have the date of report, which I said is always the current date if you are feeling live, or the date of past record if you're entering past record. So I want to ask the client, regardless of the biological sex of the client, if the client has had sex with males. The answers are either in the last 12 months, about 12 months ago, not applicable, never, or unknown. So you fill in the option according to what the client says. But the system is particular about events in the last 12 months. So if they said they've had sex, but a very long time ago with males, you can put over 12 months ago. Only when they've had it, like within 12 months preceding this visit, that you will put in the last 12 months. So as the client had sex with females, again, you ask this question regardless of the biological sex of the client. Has the client had sex with persons of known HIV positive status? The question is known. So most of the time you might get no, because they might tell you that once they know that somebody is HIV positive, they might not have sex with the person. And even if they do, then at that point, you will know maybe they're on PrEP or something. You have further, you'll go further with the prevention plan for the clients. Has the client had sex with sex workers? Regardless of the biological sex also, you want to ask this question. Is either never in the last 12 months, over 12 months ago? Has the client exchanged sex for drugs, money, or material gain? And this question is asking if the client has had any form of transactional sex in the last 12 months, over 12 months ago. And has the client also shared needles while injecting non-prescription drugs? Has the client used illicit drugs? Has the client had sex under the influence of drugs or alcohol? Has the client had sex with multiple partners? And has the client had perinatal exposure to HIV? All of these questions are also in the last 12 months or over 12 months ago. But the question of perinatal exposure is a yes or no question. So if the client's mother is alive, or the client's the mother was HIV positive during the client's pregnancy, yes. If not, no. If unknown, unknown. So has the client received the transfusion of blood or blood products or clotting factors, either in the last 12 months or over 12 months ago? Again, this form is editable. It saves the most recent entries. Whenever you put in an information, the client comes back in the next 3 months for follow-up testing, you just update the field that has changed and leave in whatever is still the same. Has the client been a victim of sexual assault? Let's say the last time the client came, the client says never, but now the client says he was assaulted in the last 12 months. So this information has changed. Has the client received a transplant of tissue or organ or artificial insemination? You answer in the last 12 months, over 12 months ago, never. If you have a confirmed diagnosis of STI at the time of HIV testing, and this question is asking, if this client was syphilis, reactive to a syphilis screening, and you are doing HIV testing as a standard procedure, you want to click yes. If the client has any other STI that is confirmed, yes. If not, no. So confirmed diagnosis of TB at the time of HIV testing. So you answer yes or no if you are screening a TB client. For HIV has routine screening. And as the client had confirmed TB, you click yes or no, select yes or no. Has the client been previously diagnosed with HIV? Because this question is for TB patients, you are going to click not applicable or select not applicable. Then you want to look at the client's condom use. You want to ask the client if the client uses condom, how often, if it's always, if it's usually, if it's sometimes, occasionally, rarely, never, or unknown. Yes, someone reason?
Yes, question again for clarity. When the client comes in and there's change of information, whether it be sexual orientation, whether it be confirmed TB or not, the history that was there before, will that be saved?
Yes, so it saves several copies, but the form only keeps the most recent copy.
Great.
Yeah, so if you want to retrieve, I'll show you where to retrieve past histories or past entries, but all you see on the form is the most recent. So you can always update the most recent and the system has all of the file changes.
Awesome, thanks.
Yeah, so this makes it easier for you not to fill the entire form on subsequent visits, but just fill information that has changed. So for condom use, if the client has never used the condom, never. If the client hardly ever uses, rarely. If the client uses on occasion, maybe they do not use condom with their regular sexual partners, but use condoms with their new sexual partners or casual sexual partners occasionally. If say sometimes, there's no condition attached to when they use condom. It just depends on their mood. So sometimes, and usually is under normal circumstance, except if they are drunk, they use a condom. And then always it means that they've never had sex without a condom. So you want to understand what you're asking and you select. Now, is the client incarcerated? Are you screening prisoners or are you screening somebody who was released from prison or has ever been in prison before? Over 12 months ago, in the last 12 months, has the client ever been homeless? You want to ask if the client has had any history of homelessness, if it's over 12 months ago or in the last 12 months. If the client is a sex worker, you want to put if the client has been a sex worker in the last 12 months or was a sex worker previously but is no longer a sex worker. And as the client had sex with transgender female, you want to answer in the last 12 months or over 12 months ago. Then you will save. Because we change a field, you want to put in the date. And then you click on save. Now notice that every single form has a save button beneath it. If you don't save and you move to the next form, you are going to lose all the change values that you put there. The reason there's a save button on the form is not just for fashion. It is to be clicked when you make any value before you moved on. If you don't click, you will have to redo all your entries. So once it's successful, you'll find it reflected, your changes reflected, and it keeps in the values that were there before for the ones that were not changed. So once you are done with personal information and risk behaviors, that is when you will see the basic summary and the important behavioral summaries, either updated for new values or inserted for a new client who has no previous record. The basic summary is populated from the and personal information form. The behavioral summary is populated from the risk behavior forms, and it gives you flags of important behaviors or summaries that you need to take prevention actions. All of the events that are in red are actions that are of priority that you need to read for a client. And they're actions that are time sensitive and happened in the last 12 months. All the actions in black are actions that are not time sensitive, but they are there because when someone has the history, the person is still at risk. So every time you want to do a risk reduction plan for a client and you're not screening the client, you don't need to read through the forms to know what to do. You find the important summaries here that helps you to take a decision on your risk reduction sessions and what you want to do, advise the client on. So we'll go back to the forms. We have the comorbidities and other information for the client. This asks for if the client is diabetic, has lymphoma, renal disease, chronic lung disease, high blood pressure, or specify any other condition that the client has. This form is optional if you are screening the client, but becomes important if the client becomes positive. So if you have time constraints and you don't want to fill in all the forms, this is one of the forms you can skip when you are screening or you have too many clients to screen on a clinic day or on a testing day. But you don't want to skip personal information. You don't want to skip risk behaviors because the whole objective of this project is to collect data, collect complete data, and collect clean data. And so you either want to take your time and collect the data completely or don't collect at all. So once you fill in this information, it also asks you for alcoholism, malnutrition, the reason why the client has come in for testing. And we have several predefined reasons here. If it's because of employment, work permit, scholarship, and there are a lot of countries that require syphilis and HIV screenings for work permit. Then immigration, there are also a lot of countries that require screening for immigration, especially for tuberculosis. If it's for insurance also, if the client is coming in for antenatal, if the client wants to obtain medical care, if the client has clinical symptoms of HIV, if the client has been referred by a partner, if the client has been exposed and wants to be tested because the client feels that they're at risk, if the client just walks in based on convenience, if the client is a blood donor, or if it's a provider-initiated testing, if the client comes for other services and you encourage the clients to know their status. Then if the client has had previous screenings for HIV or other STIs, you want to put in yes or no, the dates and the location where the screenings were done. The next form is where you record HIV screenings. Now, yesterday we talked about the test modalities, and you might want to look at the UNAIDS guide on test modalities to know how to define your test modalities. But I put the most important or the most likely to be used modalities and their definitions here. So when you want to record HIV screenings, you have a blank form here where you can put in the new screenings or enter previous screenings for this client. On the right side, it gives you the information of the previous recorded HIV screenings for this client. So this client was here on the 2nd of March. The client was non-reactive. Let's say the client has symptoms of something and you want to screen the client for HIV today. So we're going to put the client is going to be screened in a VCT site that is an NGO. The client's type of test is rapid. Let's say they're going to use determine, and let's say they're doing both at the same time, and Unigold, the both results becomes reactive. The date of the test, which is today. So once this is updated, it refreshes the page. You come back to that tab and you find the new results here. So the client has a new screening result that was recorded as reactive. At this point, you want to maybe take samples or send the client to the lab for a confirmatory test, or let's assume that in your current site, you have you are going to do a confirmatory test. So let's say confirmatory test, we use HTS recent as the modality. The type of test is an ELISA test. We're also going to make an assumption that this is several hours later, the result is ready, it was positive, and the date is today. So under normal circumstance, the result here is going to be awaiting result, but I'm just going to skip ahead and just make it positive. So once that is done, we now have a confirmed positive case that we need to refer. But before that, we want to do other screenings. You go to so we move to the tuberculosis screening, and we have the same type of form, but this form just records screenings for tuberculosis. So I want to assume in the same lab, they are going to use gene experts and do the screening. I'm going to put the type of test as experts. If you are doing a mantle test, you are going to record the duration when the client returns in the next 72 hours. And you are going to put the result here as awaiting because it's a mantle test, and the date. When the client returns, then you enter the values, put in the duration and the result date. So for this client, we're going to use the gene experts. Let's say the result is MTB detected, RIF sensitive, and the date is today. So again, I'm skipping ahead. Under normal circumstance, you might not be getting your results immediately. You're going to use awaiting results as the result, or put in the test result date as your current date. And when the result returns, you fill in the form using the date of the result. So now we have a tuberculosis screening for this client. We have the type of screening, the result, the site that it was recorded from, and the date recorded. And you will have all of the history of tuberculosis screening for this particular client listed here with the most recent first. We want to do a syphilis screening for this client. The date of report is today. The type of test, let's say we're going to do a VDRL. We're going to assume again that we have the result. We have the titer value. The result is reactive. We're going to select the date. So you don't have the result. You're going to leave the titer value blank. You're going to make the result awaiting. You're going to put in your current date. And when the results return, you fill in the form again and have your results and the date of the result. Once we fill in the syphilis, we have it here. We have previous reactive. We have this reactive now as 1 in 64, which just indicates that maybe, let's assume the dates are very far apart. This client is on treatment or has been treated, and the titer is going down in 4 folds as it should. So you might want to do a TPPA, or you might just ignore that since you know that the client previously has syphilis that is currently being treated or has been treated, and the titer value is lower than the previous titer. So this, you make your decision. In the event where the client has no syphilis, then you want to fill this form again, but this time you are doing a TPHA or a TPPA or an FTA, depending on what you use in your country. And then you will select the result and the date. But now we want to assume that we are seeing this history here. This client has previous syphilis and the titer value now is lower, so we might not need to do the TPPA because it doesn't look like a new infection. Then the other screenings, you have a list of all types of screenings from the lab that you entered during configuration. And those lists will be populated here. So I'm going to change this to go by this drop-down menu to let you type and it will auto suggest what you have on the list so that you don't have to scroll through a long list or put them in alphabetical order. But the whole idea is that you have all the screenings that the lab do on this list. If you don't have them on the list and you currently do those screenings, you want to ask the supervisor or whoever configures the system to add that screening to the list of screenings that the system uses. Then you fill in any test results information, because some screenings will not be positive or negative or reactive or non-reactive. If you do things like HB electrophoresis, your result is either the person's genotype is not about the positive or negative. So those kind of information, you fill it in here. So let's say we are doing HB electrophoresis for these lines. So I'll type H until I find it. And let's say the person is HBSS, or let's just put SS. The result here is not applicable. The date is today. So you now have all of your other screenings that has been done recorded here, and you always find a history of results that you have previously. This client is HIV positive. The client also has syphilis. We are assuming that this is the first time, although we have this client already referred into prevention care, into services for prevention. And the client's file is telling us that this client is registered into prevention care and services. But I want to assume that this does not exist. The client has not been referred. The client is not in any care and service. So I'm using this file for demonstration. You want to list in contacts for the client. Now, the client has previously listed contact information, and the contact involves household members, sexual partners, and injection drug partners. And this is the list that the prevention officer or whoever is in charge of contact tracing will see on the contact tracing page. And it's going to put in the report whether the person has been traced, tested, or the person has not been traced, and you have the list of all the contacts. So if you have new contacts on this visit, you want to ask, in the case of hepatitis, you want to ask for household members also. In the case of syphilis, HIV, both injection, and in the case of HIV and hepatitis, you want to ask for both injection drug partners and sexual partners. If this is a pregnant person, you'll be recording these contacts under the pregnancy, and you'll be listing all their contacts also. Then we have extra notes if there is any. Yes, Lester?
Just a quick question. I just came in. I've been a little late, but I have 2 questions. So
Okay.
this form that we have right now on your screen. Good morning, everybody. I'm sorry about that.
Good morning.
When we're doing general population screening, this comes up. Yeah.
Yes.
So, for example, some of the countries already have serial testing where they use one rapid test kit as for testing and one for confirmation. For example, here in Dominica, we are still doing the parallel and then we send to the lab for confirmation.
Okay.
So it's possible that when we send, after we've taken the general information from the person in terms of the risk behavior and we have to do the contact tracing, we can only start that when they come back to us because we have to send for confirmation.
Yes.
So we are able to go back into the client's
file
portal and put it in, yeah?
Yes, you update the results now. So
right.
at that second visit, you are going to be updating the results for the positive results, and then you're going to list the contacts. But then contact listing is not limited to just positive clients. You can have clients with very high risk behavior, and you're having the contact for prevention services because they're all at risk. Yeah.
So we can already start doing the contact tracing just in case it comes back, but we also have an idea of the contacts. We could also encourage them to to have the contacts come and get tested also if their risk behavior is high and so.
Yes, so because they are contacts of a person with very high risk behaviors, we are just calling them for provider initiated testing, right? And only when they are positive that you now check or cross check to see that one of their partners was confirmed positive. But on the phone or on the contact tracing is just like a provider initiated testing based on the fact that they were listed to be at high risk of having any of the diseases. So you can list the contacts. You can start your tracing, because the purpose of the tracing is to get people to know their status. And so you don't really need the results of the confirmation result of this client. You only need the confirmation results when this client comes in for testing and you want to give an appointment. So if their partner who listed them is positive and this contact turns out to be negative, you might want to put them on prep, or you might want to ask them to come back 3 months later to check again if they're still negative. So this so it's flexible. You do it however it works in your country, but you don't need a result to list contact.
Thank you. Thank you.
Okay. So you have extra notes if there is something. Let's assume like there is a situation where a client is positive, the client is married, the client doesn't want the wife to know, the client tells you that, you advise the client to try to talk to the wife about coming in for testing. You want to leave the note here so that when the client goes to another testing site or another nurse or another person is attending to the client the next time, they can see what note was left or what they need to do or what follow-up is needed. If you have a result from the lab, you don't want to enter in the result, or it's like a screening report that is not HIV or syphilis or TB, you can choose to upload the screening here. So this is a placeholder for when your system integrations are done. So if you have your lab information system integrated into the system, this should automatically populate whatever you upload in your lab information system. But before the integration is done, you have these to upload your screening results. So you have the vaccination history also. When a client comes to the testing site, you want to encourage them to always come with their vaccination card. If you offer vaccine services that are optional and you want to encourage people to be vaccinated for Hep B, for instance, maybe a lot of people are not covered and it's not like a required vaccine, but you want to get people vaccinated for Hep B, you might ask them when they come for testing if you're giving that vaccine at your site to work with their vaccination card. From that card, you can fill in their vaccine history. Again, this is a placeholder until your National Health Information System is integrated, where whatever is recorded as immunization there is automatically populated here. The last tab we have is the self-test history. Now, countries are trying to roll out self-test distribution. I will explain this. I don't know if Jonelle is on the call, and I want Jonelle to explain. The changes on this form was actually suggested by Jonelle, and she will explain better once I am done explaining what I did. The self-test report is when you give a client a self-test kit and the client comes back another time and you ask them about their self-testing. Maybe it was invalid, it was negative. You want to help them record whatever it was the result was, if the result has not been recorded by the client. The right side keeps history of the self-test kits that you have given to the client. It also gives the history of condoms that you have given to this particular client. So when you do your prevention service and you give condoms, the system automatically tags the condom against the client so that you know the number of condoms that was given. And you can see this history regardless of the sites that the condoms were given at. So if you have a client who goes to site 1, get 10 condoms, site 2, get 10 condoms, site 3, get 10 condoms, you see the dates given. And if it's a pattern that the client used to collect packs of condom from all sites in one day, you might decide that you just received condom from this site today. I can't give you right now, or whatever it is you want to do. Then you want to see the self-test kit also. Jonelle suggested that we have serial numbers written on the self-test kit. Jonelle, can you take over from here?
Hi, good morning, everyone. So the suggestion that I was thinking, seeing that we had, for some of the countries, follow-up may have been or might come in as a challenge with the self-testing kits. I thought, well, the idea was to upon distribution of the self-testing kits after rollout at various sites, that each site is given a code or a number, or it could be the serial number of the self-test kit itself. It's recorded on the form, or it's on the packet, or it's highlighted so that the client is aware of what that code is. And normally, well, to log into the case-based surveillance, there was the self-testing reporting form out front, that the clients are guided to that form to enter the information there. And the code that is given to the client at each of the site, or any of the sites that they go to, they use that as the ID for the form at the welcome page. And all of that is accumulated, or it's gathered somewhere within the case-based surveillance, that the national surveillance person is able to gather, and as such able to reach out to each of the clients via the information that is entered at the welcome page. Now, the code that is written on the form or highlighted would also have some ID to the site. So for instance, let's say the form was given at the national level here in Grenada. So it would probably be NIDCU, NID, and whatever number is attached. The surveillance person will now open that list, can highlight the site via the first couple letters. The number would tell you how many, probably could tell you how many kits was given, what is the number of kit that that person got, and able to reach out to that site to ask the manager, the supervisor, hey, can you just give me the details attached, the basic details attached to this particular kit that you gave? So supposedly that the person did not submit a result, the site will have the basic data. And if it is that the person did submit the results, then the site can give further details so that the surveillance officer can reach out to the client. So that's the idea that I thought of. Mildred added extra things with the condoms and everything else. So Mildred, that's what I was thinking.
All right. So this addition actually works. It's actually what you wanted, right?
Yes, to some, it's more than what I was thinking. However, though, what I wanted to see or was looking for is something where you can see all of the test kits that was given. So it's more for the surveillance and for follow-up at the national level. So if there's a form that can show you all of the kits that was given out by and all of the sites that gave them, then yeah, something to that effect. It helps with follow-up and reaching out to persons, clients, recording data if any was missing.
Okay, so now the supervisor is able to see all the kits that was given out and can see all the ones that were reported. So the supervisor can actually export this to Excel for further analysis. Right. So they can compare kits given versus reported here.
Right.
And can also get, so this is on the national level, regardless of the site where this was given. And so the supervisor can see all of the kits that were given out, whose test was used and recorded, can see all of the kits that were given out in total on a national level, can also see all the condoms that were given out and where the sites from where it was given. So if you want to get the total figure, you want to add everything here and everything here. So these are all exportable tables for further analysis on the supervisor's end.
Yes, Mildred. That is what I was looking for. The test kits, once it can show, once the client, or in some countries, the client may be the one entering on this welcome form, or it could be the site, whether it's a pharmacy or an NGO, entering it on this form. Once the ID, the ID that enters there, you have it as optional, Oh, you actually entered serial. Okay, you added
Yes.
that other thing. Okay, all right, I
Yeah.
got you. Because we're going to use, we could, in my mind's eye, I thought that the serial kit number or the ID number, either one can be used.
Yeah.
And as long as the code that is given at the site is entered, that is what is going to be able to connect the surveillance list to the site and the kit itself. That is
Yeah.
the most, that is the most important. Not even the result, as far as I could tell, is important. Once that code that is given at the site is entered, then the surveillance person at the national level can be able to connect what is entered and what was stored at the site. And even if something is not entered on the form, and the surveillance person at the national level is doing their monthly or weekly follow-up, and that code is given to her, she know, or he can now pick it up, enter it into the system via contacting the client to find out what was the outcome. I know for some countries they may not want to, at this side, they may not take take names and so forth. In this case, Mildred had given the basic code whereby you use the person's initials and so forth. That can also be used to enter, so that there is still that anonymous feature, so that the clients can be a bit more comfortable in submitting and speaking to the pharmacist, if it's a public pharmacy or a private pharmacy. So Mildred, this is perfect. This is what I was looking for. Thank you.
All right. That's nice. So anybody else has suggestion or feedback on this?
Hey, everybody, please give comments, say something. I don't know, say something. I didn't make it that perfect.
Good morning, Mildred. Morning,
Good morning.
colleagues. Janelle, I think your suggestion is very worthwhile, and it has its benefits for countries that would like to utilize that system. As you quite rightly said, some countries may not have a national repository, as it were, but so I want to ask also, would that information work horizontally as well?
Yes, it's very flexible, so it will work whichever way you want it to do. So you can actually decide what you want in country and use it the way you want it. So if your site is the only one distributing test kits and they're not doing it on a national level, you will distribute the self-test kit in your site, and you will get the test kit you have distributed. Now, one of the features added to the general population counseling and testing is the ability for you to distribute or record self-test kits distribution. And once you do the recordings, you will find all the recordings you have done. So if you are doing this on a site level, this gives you site level access to record self-test kit distribution and to either update distribution or to get all the distributions of self-test kits that you have done from your site. So it works in whatever way. In the event where you give clients the site address for them to go on the site and record their self-test results anonymously, you can tell them to record on this form. If the client is a client that has an account on the system, has a unique ID, you might want to ask them to put in their unique ID here. If there are clients that have maybe collected 3 self-test kits and said that the 3 kits are for their both sexual and injection drug partner, and she always wants to know their status before having any needle sharing or sexual encounter, then she might skip unique ID because they do not have any unique ID. Use the serial number on the test kit, either a serial number or whatever number that whoever is distributing writes on the test kit, and then put in the type of test, if it's mail-in or rapid at home, the type of test kits will have a name of the manufacturer, so you put that type there, and then you put in the category of tests, because there's also, if you have a dual HIV syphilis or just HIV or just syphilis self-test, so in the event we start syphilis self-test in the future, you don't have to review this. And then you have the results for HIV and the result for syphilis. And if they have any comments or questions, they can put it in here and report the self-test. And then whichever the testing provider is can reach out to them, or if they have a positive result and they want to come into the site, they can actually link their self-test to the account.
Mildred,
Yeah.
question. For that particular form, I'm thinking in from the perspective of a client, right? Some clients will enter the category of the test, right? Some clients, my question is though, the required, if I don't fill it, would the report still be sent?
Nope, it's going to block you from reporting. See?
Right. So the downside I'm going to see with that is that some of the clients, hypothetically speaking, a client comes in at an NGO and receive a self-testing kit for free, right? We tell the client, hey, this is an HIV. When you get onto the form, you click HIV itself. And that's providing they go onto the site, right? Worst case scenario. I would like to suggest that that category be optional. However, though the site that gives the test can record what test is it in collaboration or connecting with the ID code, the code that is given at the site, that is the serial number. And if it is that client can only enter and will only enter the code and the test result, I would suggest that we allow that to go in, and whoever it is on the national level that is going to be doing the surveillance, reaching out to the sites, and the surveillance person realizes that data is missing, then the site that sent out the test can now provide that missing info for the person to enter. Because hypothetically speaking, there will be clients that probably will just be deterred by the fact that they have to enter all of these required stuff. And again, I'm just being worst case scenario here.
Okay. Yeah. While the concern is noted, you want to collect complete and meaningful data, right? Majority of the time, when a client comes to the page and wants to report the test, they'll likely fill in all the required fields. A client that is not willing to fill in fields might not even come to that site. So you want to tell the clients that at their convenience, they can fill in the form, or they can decide to come into the site and let the care provider help them fill in the form in the event that they come in for follow-up or come in for another service. You want to fill in what they collected the last time. So once they go there, because if you remove this category, it's going to create a lot of problems in that the surveillance officers or the care providers will have to manually, one by one, update all of these categories. Even if the serial number links the kit to the category of test that it is, you will still have problems with trying to update all of those fields. So it's just one extra field. The client can choose to do it or not record at all. Just make them know it's a choice. If they want to do it anonymously, it's better they do it themselves. If they want if they want to be helped, and they come into the site. So for people that want to be anonymous, they'll prefer to record it themselves. And so at that point, I don't think we can completely beat the differences in human behaviors and what makes some people happy and what doesn't. We just have to do what gives us the data that we want. Okay?
Mildred, question.
Okay.
In terms of the, good morning, everyone. Sorry.
Good morning.
In terms of the serial number, okay, serial number required, but the serial number would not be unique to a kit. It would be unique to possibly a box or a shipment of the kits. So in collecting our data, if a patient enters the data or submits that form or decide to complete this form on more than one occasion using different ID, is going to give us, but the same kit, but they may make different entries. Maybe they have forgotten they entered it already, or maybe they think that they left out something and they coming to re-enter. But they use different ID. The serial number is the same. We're going to get a false data because it's going to look like 3 tests were done when it was only 1 test.
Okay, so that is why it is an Excel, is a table that can be exported to Excel to be cleaned. Because once you have a client who records 3 times, maybe the same, and some values change, you can always compare the recordings that the clients do with what was distributed, and then clean out what it was an error on that entry. Now, the serial number here is just there in case if each individual kit has a serial number. But in the event each individual kit doesn't have a serial number, you might want to write something with a marker, maybe 001. So if you have a box of kits that has a serial number on the box, so that box has a serial number, but the individual kits is numbered, because you have clients that will come in that you give more than 1 self-test kit, right? Not just 1 for each client. And then when you want to record what you distributed, you have to be recording a bulk number. So maybe you say you gave that client 001 to 005 or whatever it is that you number. So the serial number field here it depends on how you want to number your test kits in the country. So it's just flexible. Mistakes will always happen, but that's the purpose where you have what is distributed versus what is reported for you to be able to clean your data.
Okay, thanks.
All right. Any further question?
A question.
Okay.
A person does a self-test and it comes back positive. How do we get that person into care?
Okay, so I want to assume that based on regulations in the country, when you give the test kit, you have your form if you are registering manually, right? Where you have the contact information of the person. Or you tell them that if it's positive, in the comments, they can leave their phone numbers if they want to be contacted. Because you see the form here has a comment section where the clients can actually put in anything they want to put in there here. So if it's positive, they can put in a number if they want to be reached. If it's a client whose unique ID, who is a client who has an account on the system, and on distribution, you put in their unique ID. Once it's positive, you already have all of their personal information there. If it's a client who is not a client, who comes for maybe an outreach, or you distributed during an outreach, and you are giving the test kits, there'll be some form of counseling. If this becomes positive, you don't need to panic, right? You're going to give post-test already. You're giving both pre-test and post-test counseling on distribution of the self-test kit. So they know what to do. If they want to take their time, take 3 months before they come in, after they have a positive result, you just make them know that whenever you have a positive result, you might want to go to your nearest health center or the place wherever you collected it from. But the thing is, you decide within country what you are allowed to collect. If you're allowed to collect the contact information on distribution, you have those contacts for you to follow up with the client. If the client does not report the self-test, and possibly you want to give a timeline for a number of months before you contact people who have the self-test kit to ask them if they ever used it and what was their result, then you can also do that and say, okay, you gave out self-test kit in October last year, this is March. I want to find out those who never reported the self-test, if they used it, what was their result, and then you record it.
Okay, thanks. I assume, thanks. I assume anybody who's motivated to do a self-test though probably would want to come into care. So that might help us to get persons into care.
Yes.
I have a question. It might sound like a dumb question, but anyways, at the back of my mind. Again, you said when we are out, once we have that on our device, we can just enter the information when we come back into Wi-Fi or whatever. You just upload it, yeah?
Nope, we don't do offline here because you don't want the device to store any information of HIV of anybody.
Oh.
Because except we get to a time where you have government controlled devices that are given to you for these purposes. You don't want to have those offline modes.
Well, again, as I'm saying, wow. So what happens to our outreach sessions then?
So if you are doing outreach, if you have mobile devices, you might want to use your data. If not, you want to collect it on paper. But what you don't want to do, what's this? You want to ensure security. And if you do the offline, it means your device is storing information about people, and the sensitive information and the personal devices. Yeah.
Yeah, well, something just, it's a good thing I asked that question, because I mean, the major changes that have been made to this in terms of the information that it collects and the paper-based testing and counseling form that we have is vastly different right now.
Okay.
It's extremely different. Again, I think at one of the meetings that we recently had, they were mentioning getting devices for something else. I guess those devices will have to be used for what they were looking at doing with them in terms of the meeting we had and the entering the data, the past data.
Yeah.
I think most, especially for the government system, we should be able to use the same devices and know that it's government secure because it's a government device that stays at a government facility.
Yeah.
But I'm starting to think right now it means that we'd have to make major changes to the testing and counseling form that we have in comparison to what you have. Yes.
Lester, we did that a lot of years ago when CaseBase came out in 2018. We took the same risk assessment questions that was in the form, and that's what we use out in for testing and counseling. So we had migrated all of the questions, and whenever we go out, we sit with the clients for 10-15 minutes, and it helps us with engaging the clients too, because we get to realize a lot of the clients didn't even know what oral meant. And that's what we ended up using as our main testing and counseling form. So we got our responses and we enter it into at the time we said enter it identically into the case-based system.
Yeah, that's cool, but we're doing the same thing right now. What I'm saying is some of the changes that Mildred has made on this system is a lot more extensive than what we had on that case-based, that testing and counseling form that you have and I have right now. If you look at it, it's a lot more extensive. So I'm thinking right now, it means that you'll have to sit with the client out there when you're out, do the testing and counseling form, which has to be edited right now based on what is on this, plus come back and put it on the system. So what I'm thinking, especially for our system on the public system, like for example, we have computers, we have laptops, we have a few tablets here. We may have to find a way that this thing is done with somebody having a tablet in front of them when they are out, and when they come back into the facility, once they get on the internet, it automatically uploads it, but it would be a government device, it would not be a personal device. Because that's a lot more extensive now what we had before, Janelle. You're talking about all the self-testing thing, all the changes that Mildred have made to make it, which is very good, but it's not that's not what we have on paper right now.
So in the event, yeah, but in the event you want to use paper, you can just come to this form, screenshot, or just print out the forms from the system on the pages, right? And use the form. So you don't need to go edit or redesign forms, just print out what the system has. So when you collect this information, it's already identical when you come back to enter them.
You can, that will be able to print out the entire form with all the risk factors, everything.
Yeah, you can print them
page by page, or it gives it to you in one thing. You need to show me how to do that.
Okay, because so I will either export them and email them to you before you go live so you can use them, or okay, I will show you how to do it.
Well, so no problem. That sounds pretty good. Once it has the information. All right, good.
Okay.
So Lester, internet in the field isn't an option.
Well, again, that's what I'm saying. Again, internet in the field can be an option, but you have to understand with all of the small islands, it's different. If I'm going to do testing for the sex workers because I'm engaging them, let's say in one of their bars or whatever, they may not have internet access. And it will mean that you'll have to put again the Wi-Fi and password on all devices that you have if they have internet. That's my concern. If you're in a government facility or you're in a fixed facility is one thing. When you're out there, It's different, and it's not everybody's going to tell you, yo, I'm doing government work, I'm going to use my data. You have to bear that in mind.
But I'm just thinking that you could use a hotspot, but then the government will have to give you that data, right?
Exactly. You'll have to get the hotspot from the data. And again, let's say you have 5 or 6 testers. It will mean that if you're hotspotting, which I'm not so much an IT person, but I'm thinking, if you're hotspotting from one specific device, it will slow down the movements of every other device, if I'm correct.
Let me tell you.
And you'll be hotspotting for hours, as a matter of fact.
Exactly,
Sometimes
you'll be
6, 7,
hotspotting for
8
quite a while.
hours. Yeah.
Exactly.
So it will drag on your data badly.
Okay.
And then apart from that, when you go on the field, you meet all levels of people, different levels of education and enlightenment. A lot of people panic when they see you holding a device to record their information. They'll prefer paper. Yeah, so you might want to go on the field with paper to make everybody comfortable. Because if there are situations where people hold device to want to record information and nobody wants to talk anymore. They come with this mentality that they are submitting our information to somebody. A sex offender will say it's to the police. Somebody will just bring out something, and then you might want to just do all field on paper and come and record them on the system to prevent make people comfortable.
Yeah, because they might even think you're doing recording audio.
Yeah.
Yeah.
Mildred?
Yeah.
Miss Bradison had her hand up. I don't know if she still wants to ask, but I also want to ask something after she speaks.
Yes,
Okay.
I sure do. Thank you very much. Yes, Mildred, I support what you're saying with the paper, because I know persons will have a number of questions if you have a device. But depending on the situation, I still think that the device might work. Yeah. According to some of what Lester was saying. But then if you have a government phone, for example, when we go in the field, if I'm going to do some work and I'm using case-based, because I have a government phone that has internet, then I use that hotspot. So if you have a government phone and they give you access to internet like that, then that can work, but then we still need to guide with regards to the situation and if we're going to use the internet when paper would be preferable. With regards to the self-test, someone had asked regarding if a client gets a positive result, what they should do. Right now, we are in the process of executing, or we are executing the self-test here in Antigua. And the form, the questionnaire from CMLF deals with that. If you have a reactive test, what's next? So when the person collects the test, the self-test, that information is given to them. They have an option that in the case of a reactive test, if they would want to confirm that at a public site or at a government site, or they can come to the NGO. So all of that is covered when you roll out your pilot. So it's the same way that the pilot is being done. You will have to roll out at a national level where persons will know the importance of having a confirmatory test done after having a reactive test, the importance of entering care. So all of those things are done when the person collects the test. You brief them on that, and then they can be given a little card that has the information, the different sites that they can contact if they have that reactive test. So I just wanted to share that. Thank you.
Thank you. Yeah.
Mildred, if I may say, using the tablet is something that we have done in Antigua when we have done studies. You don't necessarily have to have data on the tablet at the time when you're inputting the
in the
information.
self-testing format the meeting. And we have to talk a little about the ECBS and how we're going to get the form from us on. Sorry.
Hello? Hello?
Hello? Yeah.
I'm sorry.
Okay.
Okay, you input the data, and when you reach to a place with Wi-Fi, immediately it is picked up. So you don't necessarily have to have Wi-Fi at the particular time when you are collecting the data.
No, but
I don't know what systems are in other places, but when we were doing the MSM OECS study, many of the places that we would have gone to didn't have Wi-Fi, but we could collect the data and press enter, and when you reach to a place with Wi-Fi, immediately it is sent.
Yeah. But you see, the information from those are not as sensitive, and there is no structured accountability right now. So the system does not support any offline mode for now, until that structure is established. Because there is no guarantee that people will go on the field and not use a device that is not authorized just to make the work faster. There is no top-level supervision to guarantee that. Then secondly, there is no guarantee that nobody comes, people who have government devices, there is no structure of accountability so that at the end of the day, you must submit the devices and not go home. So you take it from the government site, go to the field, submit it back before going. But once you have government phones, government tablets that you can take to your house, you break all the system security because these things store this information on your device. And you don't know who will have access to these devices in your household, or if you keep the device carelessly. So because of that, when we're building the system, we decided there's no offline mode because it's going to be difficult to establish that level of supervision that you need to secure things properly. Yes, Lester?
Yes, thank you very much. So I would want to posit here and now that, and this will be at a country level, for NGOs that have testing sites, special arrangements will have to be put in place for those NGOs as well.
Yes.
Thank you.
Okay.
So yes, Mildred. So I somewhat understand what you're saying, but I don't totally agree with it. I think if persons are using government's device to do stuff, that those devices should be secure devices and not for personal use. So you expect people to be professional on a level of responsibility, that if we happen to have done testing and we leave at 7 and 8 o'clock, and you use a government device, an iPad or whatever it is, that when you get home, that is secure, it has a password on it, that people of your family should not be able to use it. And I think the same should filter down to our NGOs, that if they're using any devices that belongs to the organization, that it shouldn't be something that you use for work and personal stuff. Because it's really going to be difficult anyway you look at it if people are going to use data or use personal devices to do that type of work. Something has to be put in place. I know for certain, I can completely sure that each government facility has at least 2 iPads and at least 4 computers that they have gotten from the Global Fund. Yes, countries are bigger than others, but I know that those things exist because I have those things there that we got from Global Fund that we use every day at the office. So there are devices available. If one office, for example, have 4 or 5 testers, there are computers or laptops for almost everybody. So I really think that we have to look at this thing closely because it's going to be really a push and pull to be out there with or without a device, come back into your office, enter all of the information. You see 5, 6, 7, 8, 9 clients and have to sit down and enter all the stuff when it could have been just entered. Karen made a point as to we're moving into the 21st, 22nd century. If you have a device in front of somebody and you explain to them carefully that I am only using the device for taking information from you, people shouldn't feel insecure about their stuff is going out in the clouds when you have already assured them from a professional point of view that you're doing this because it saves you time and not having to have it paper-based and stuff. So I think that we have to look at it from that angle. We're not backtracking. We are moving forward technologically. So those are things that we should be able to explain to clients, and clients respect and understand that you are seeking healthcare. Just like if you go to the hospital and they have a system and they take information from you, it's not for all of the world to see, but it's within a secure setting. It's a secure thing. I just wanted to make that point.
Yeah, but Lester, that's I'm trying to make people change their mind about what they think or when they have strong opinions. It's going to be an impossible task, even if we move to any century or we get.
But again, no. The thing is, when we did the MSM studies and the other sex worker studies, we were using devices and people were not so finicky about where the information is going because we explained to them what you're actually doing and what you're trying to achieve. I think the same thing applies here.
Yeah, but the application here might not be as acceptable as that for the size estimation studies. And I'm saying this because if we go look at the whole, let's use COVID for instance, and the COVID vaccine stuff. While people have their genuine concern, you see some advanced and very educated people who you expect to be able to inform people better, going with their own theories, and you can't change their mind no matter how you present the facts. So it's going to be the same thing when you want to do, especially for provider-initiated testing. If you have people seeking care, it's easier because they came to you. But if you are going to them and you want them to know their status and you want to encourage them, you are giving them for free, then they become skeptical about what you're trying to achieve. So it's a little different when you are dealing with a larger population of people and you are the one actually targeting them and they're not the ones targeting you. So you might still have problems with devices, but again, it depends on the environment you are going to. It depends on the report you get. If you go on the field once and devices are an issue, you might want to not use the device. If it's not an issue and everybody understands that everybody is recording things digitally now, you can use it. But to say that people will accept, you won't be able to control how strong people's opinion on issues are, no matter how educated those people are. I saw another hand raised. Yeah.
Yes, Mildred, I recognize and I hear the concerns of some of my colleagues. In providing care, there's always the areas of risk and trust, confidentiality, and everything that goes along with it. And that is why I may be deviating here a bit, but bear with me. And that is why it is always better for the persons who have worked in the community with the key populations to do the outreach, because they are known and they are trusted and they have been working with the key populations for a very long time. I know with any new system that we are a set of ingenious people, and that we can work around how we can collect the data that is needed. So while we're having our discussions, let us look at meaningful and innovative ways which we could capture the information that is needed when we do our outreach or at any given time. Thank you.
Yeah, thank you. Okay, yes, I'm seeing something in the chat. Yeah, and Janelle said that this time this is highly dependent on countries' preferences. And also, yes, it's going to be handed over to countries. And at that point, you can actually change things to suit how things run within the country. Okay. So if we don't have any further questions on this, we can take a 10-minute break and then we'll return and conclude today's agenda. Is that okay?
Yes, that's fine.
Yeah, that's fine. That's fine. Thank
All
you.
right. Okay. So before we went on the break, we looked at the self-test. And then we have a question, how the clients are going to get to this self-test form page. Okay. So every country has their site address. So for St. Vincent, for instance, you have svgcbs.org. Dominica has domcbs.org. That is the site you give to the client. And when they go to that site, they will find the form on the welcome page. They don't need an account. They don't need to log in. They just need to fill in that form when they report their self-test. So if you go to this site, you'll see that this particular form is mobile friendly and it's going to be at the bottom of that page and they'll be able to report the test. So what you give the client is your site address. If the address changes in the future, you want to update. So in the event where after the handover, countries are relocating out of that domain, then you want to give the clients what domain they are going to be. They'll go to record their self-test. Okay, so we looked at how we can fill in information for a returning client. And the last thing we saw for that client was the self-test. Once you are done with a client and the client is positive for, let's say, HIV, when you come back to pages menu, you will find a referral submenu here. There are 3 types of referrals here. There's a refer new HIV case for care registration and management. There's a refer new TB case for treatment and management. And then there's a refer for other treatment and management. So for people who you want to send for pre-exposure or post-exposure prophylaxis, you are going to be using that other referral. For people who do not have HIV or TB but have other STDs, you are going to use this referral. Now you can decide to refer a client for the 3 different referrals if they have the 3. But if the client has HIV, you don't need to bother about TB or other referrals. Just refer for HIV and the care registration and the clinical care team will do the rest. So the rule is this: it's optional if you want to do 3 referrals for clients that have all 3 or belong to all 3 categories, or you just refer for HIV, which takes priority. So if the client has only TB, no HIV, you refer new TB case. If the client has other STDs, no HIV, you use other. If the client has both TB and other STDs, no HIV, you do both referrals. If the client has HIV along with anything else, just refer for HIV. Again, it's not a fixed rule, but it's the most convenient way to use it. You can refer for all, you can refer for just one. So this client's information has been collected. We are going to come back to the referral, but before then, let's look at the prevention services. On this container above, we have 2 flags at the bottom. One flags that the client is positive for HIV screening, and the second flags that this client is already in care for prevention services. If we don't have these 2 flags here, but this client is non-reactive to all of the screenings, but the client has a high risk behavior, you want to click on Start Risk Reduction. So you're not going to refer a client who is non-reactive to all the screenings. You're just going to click on Start Risk Reduction for those with very high risk behavior. It brings you to this form. On this form, we have the questions for you to record your risk reduction sessions. It asks you answers to the questions when you talk to the client. So the first one is, clients will talk about HIV concerns or risks to partners and friends. If the client says yes, you will say select the option. Client will talk with partner. If the client says they're going to talk with everybody they know, client will talk with others. If you have anything not on the option that you need to type in, then you can type it in below the answer. The next one is client plans to discuss HIV testing with partners and get them tested before having sex. So this one relates to the sexual partners of the clients. And if the client said they're going to bring in their partners for testing before sex, or they're going to use condoms until partner knows their status, or they're going to abstain from sex until partner is tested. If the response is not on this option, you want to type it in here. So let's say the client is going to bring partner to the site to be tested. The client plans to change or stop seeing high-risk sexual partners. Let's say the client says they are going to break up with high-risk partners. The client plans to change certain type of sexual partners. Again, if the client has high-risk sexual partners and the client is saying that in the future, they'll try to get to know their partners before having sex, or they'll want to reduce their number of sexual partners or abstain from sex completely. So let's say the client said they want to remain faithful to one partner. All of the fields below is for you to record information that is not contained on this form. Before I scroll down, I will fill in the dates which is required. We have the next, which is clients plans to stop alcohol or drug use. So these are for clients that maybe during the session you mark alcoholic, or they always have sex under the influence of drugs or alcohol. You want to select an option. Let's say clients will avoid places where he or she uses drugs or alcohol. You type in any other response here. Client plans to increase condom use. Let's say the client is going to accept condom and the client will use condom when having sex. So other plans that the client has. Let's say, for instance, let's say client wants to be placed on pre-exposure prophylaxis. So let's say other plan. So you're going to do this referral for the client. So this is going to be important when the client is not a positive client, but the client we're using for this example is already positive, so the person is going to be on ACT. So the next thing the next question here is did the client receive pre-test counseling and the date of the counseling? So if the client receives, we'll say yes, and they received the pre-test today before we did the screening. Did the client receive post-test counseling? Yes, and the date is today. If you have pamphlets on HIV, all these information forms, and you give to clients, you want to select yes. If you have condoms and the client is going to accept condoms, yes. You put in the number of female condoms that the client collects, let's say 3, and collected 5 male condoms, and we're going to save this. So this is your prevention form where you put in information for prevention for the client. Once you are done with this form and you come back to the client's page file, you will find that there's a second button here that gives you a link to look at the history of risk behaviors of the clients. The system only selects the last 3 recorded. So this is one of the places where you find all the logs of the different entries for the forms. Because we only entered the risk behavior twice, the system has both recordings here. So if you want to review before the most recent, what was the risk behavior, you'll find the second most recent risk behavior. Every of the container holds previous recordings of the risk behaviors with a timestamp for you to know the time difference between this recording and that recording. So if you are monitoring the client's risks and sees that for subsequent sessions, this risk is getting better, the risk reduction plan is working, you can keep to it. If the client is still at high risk and is not keeping to the risk reduction, maybe you want to take another action. Or offer the clients pre-exposure prophylaxis or whatever it is that you do in the countries. If the client is your first-time client and the client has been somewhere else and you have all of this previous history, you want to look at the client if this client is already on a risk reduction plan. You click on the last button here, which is risk reduction plan history. If the client is already on a risk reduction plan, you'll find a history in rows of all the risk reduction session that the client had in the past. So this gives you the information you need to proceed. Now we have a direct access to all of these risk reduction forms on the system from the client's page. But what if the session is just a session for risk reduction and you don't want to request access to the client's file, or you don't even have a general population counseling and testing permission? You're just a prevention officer, or you're just there for prevention and control. Providers whose job is for prevention and control will have prevention and control submenu here. This is the shortest method of getting to prevention and control for a client without going to the client's file. If you want to look at the client's risk history, you click on Track Client Risk History here. You enter the unique ID of the client, Get. And so it gives you the same form that you get to directly from the client's file. If you want to start a risk reduction for the client, you type in the unique ID. When you start, it suggests all the IDs, and then it gives you the form for the risk reduction plan without having to get the whole client's file. If you also want to look at the risk reduction history, you click on risk reduction history, start typing the ID, and it auto suggests what is there. And you get a list or in table of all of the previous session recording. So you can either go through the client's file and find those information, or if you have prevention and control permissions, then you can go through prevention and control, enter the unique ID. Any question before I move further?
No question from me.
Mildred, sorry, where did you go to get this screen? Sorry, I missed that. Somebody walked in the office.
Okay, so this time you go to prevention and control /PMTCT. So if you're not going through general population counseling and testing and requesting release and collect information, you can go to prevention and control. If all you want to do is look at the risk reduction history, you click on that, enter the unique ID, and it gives you that risk reduction history without you having to retrieve the client's whole file and going through that process. So this even helps you to give prevention permission to contact tracing officers without having to give them VCT, general population counseling and testing permissions. Then we have another set of functionalities, which is the contact tracing, and this is under prevention and control /PMTCT. All the contacts that you listed during data collection for a client is going to be displayed here. We have two batches of contacts, the ones that are listed from people that are not pregnant and the ones listed from pregnant clients here. You can print out this, you can export this. The last two rows, or the last two columns, sorry, of this form gives you the status, if traced or not traced, and the tracing report, if the client has been screened, if the person was traced but refused to come in for testing, whatever the conversation was about here. You have 10 per page until you get to the last set of clients. This list is just to inform you how many people have been listed as contacts for one or more of the diseases. When you come back to the prevention and control, we have report tracing. So let's say I want to take in this unique ID that is not yet traced. and I want to report tracing. Because I took the ID from general population, not from a pregnant person, I will put in the contact code here. Now, I'll go back there to show you something before I move on. On this list of listed contacts, you have the unique ID of the person that listed them, not the unique ID of the listed person. So this contact is linked to this person on the system. So if I come back to that, I want to copy, I'm not taking the unique ID, but I'm taking the contact code to report tracing for this contact. I will come to prevention and control, report tracing, and I will enter the contact code for the report. Now, let's say I trace this person today, and the report was that let's say I went there with a rapid test kit. The person gave an address to come over with a rapid test. The client was screened and had a non-reactive result. So let's say client was asked to come to the site for prevention services. So let's say this is the report. You can put in whatever report you have, and because this tracing is complete, you mark as trace. If your report indicates that this person's tracing is not complete, do not mark, so that the next officer that looks at it will know that this person was contacted, but the person has not been, the tracing is not complete. So you define completeness of tracing based on what you do in your country, and then you submit. Once you get this success message, you are going to be redirected back to the page. If you come back to prevention control here, you are going to see listed contacts. I will go back to that ID, and I will see that this has been updated to have the status as traced and the report of the tracing. Yes, Lester?
This aspect of it, I think, is really, really wonderful. What I was thinking, though, is there a way where, let's say, using the contact code, that we could see if a contact is linked to a number of other contacts that shows up on the screen? We can pull it out. No?
No.
Okay.
There's no way to know if a contact is linked to other contacts, but you can know if the primary person who listed them is linked to other contacts. So the index person is the person who listed, but the people who are listed are only linked to other contacts if you create an account for them on the system. But before then, a contact code cannot be linked to anybody, cannot be linked to other contacts, but can be linked to who listed them.
So if, for example, I know that you were showing an aspect a while ago, a component where people give you the contact, the people that they've been in contact with, they may just give you the person's name because they don't have the person's personal ID information or whatever.
Yeah.
If that other person comes to get tested, so let's say I'm HIV positive, I've given Jim Jones as my contact.
Okay.
Yeah?
Yes.
I'm positive. I'm giving Jim Jones as my contact. He comes into the system, he gets tested. Yeah?
Yeah.
I give Brenda Lee also as my contact. She comes into the system, she's tested, and she's tested positive, or she comes into the system to get a test done. Is there a way where we can identify that these two persons would have been contact from me? Because you see, you were making a point earlier as to people's risk. There may be a number of people that, especially, well, let me just rephrase it. Sometimes you'll find with the MSMs, they share partners or they have threesomes or whatever they do. So you want to make sure that you can capture as much and see where the risk is, why the risk is there, and so on. So is there a way that you can have it where when I pull it up, I can see that there are a number of people who have been running around that specific person's circle?
Yeah. So what you're saying now, you want to have a web of connection between people.
I mean,
right?
yeah, but I mean, I don't know. I don't want you to put. I was saying that. I mean, it would be kind of interesting to see because you'll be able to, outside of the numbers, able to see patterns. But I mean, you don't have to do it. I'm just saying, I just thought it would be able to.
No, yeah, it's actually an interesting feature I thought about, but I'm going to actually put it there, right? But what the system does for now, it only tags pregnant clients to the unique ID of their partners. So if the partner is positive and the pregnant client is negative, the nurse will know that this person has a partner who has high risk behavior and she's pregnant. But now, the only thing that happens here on the forms is that there is a link between, so the relationship now is many to one, not one to many. Many to one, that means one unique ID can be linked to many clients, many contacts, but one contact is linked only to one unique ID using contact code. When this contact, for instance, comes in for testing, this contact now has an account on the system. The contact has a unique ID. So let's assume that when this client was screened, the client was negative, but due to very high risk behavior, this client now listed contacts. This Noah Oliver is one of the contacts. Noah comes in for testing. Noah tested positive, while the person who listed Noah was negative or non-reactive. Noah now tested positive. Noah has an account. Noah lists contacts. And this primary person who listed Noah becomes a contact of Noah. Now, Noah is now the index positive person. While this person was the index who listed Noah, this person now becomes the contact of Noah. So you will now definitely, the system already, there is no visualization of the web, but the database has that web. So I'll actually visualize it where you can see how connected people are. Then you find that this person is going to be screened again because now a contact, even though the person has an account on the system, the person now has a partner who was positive and flagged as positive and now linked to this same client who was non-reactive during the last screening. So you are now going to be tracing the client who is already on the system who was non-reactive, but one of the client's contact is positive. So you're going to retest the client based on the time gap you want to use. And then it now becomes a loop. This person now becomes positive after some months and now lists contacts that were not listed before. And the contacts are now tested and now list other contacts, and the other contacts are tested and list other contacts. And it always comes back to the same group of people with more people added. Does that answer your question?
Yep.
Okay. I saw another hand raised. Somebody else had a question? Okay. So once we have the report tracing, if you want to refer any of the clients that are in for prevention service for care registration and management, and when I say care registration, I mean that when they become positive for any STI that is not HIV, or they want to be on post-exposure prophylaxis or pre-exposure prophylaxis, you'll use this PrEP or PEP referral form. It is the same referral that you do under the referrals for prevention services, but this is a shorter way for prevention officers to refer people for pre and post-exposure or other STIs. If you want to filter the list of just people who have not been traced, then you use the unlisted, untraced contacts. And so this does not give you everybody who was listed, but everybody who has not been traced. And so you can always print this out for the tracing officer to go and find out or to trace these ones and produce a report for the tracing. Then we have pregnant client registration / PMTCT data form. This is just an information form that alerts the PMTCT officer that there are pregnant clients who either were reactive or positive for HIV and reactive or positive for syphilis screening. All this does is just to do a PMTCT registration. It is not the clinical management form. And these are automatic flags. They're not flags of anybody registering anybody, but they're flags that the system automatically generates on this page for PMTCT to see that in a testing site, there are people who are pregnant and one or more of their results are reactive either to HIV or syphilis. The flags are generated as soon as the person becomes reactive, even if the person is not confirmed positive. If the person goes for a confirmatory test and the confirmatory is now non-reactive or negative, then the system deactivates and removes the person from this list. So it gives a unique ID of that client and the pregnancy ID that triggered this flag, the dates that that flag was triggered, and then it gives a form. If the person is already registered into care or referred for registration, this form is going to load to just allow the PMTCT officer to put in other information for these clients. And it only wants to see if the person has started treatment for syphilis and guide the clients to be registered into care for care registration and management. So it keeps the history of everybody who has been flagged, and it allows for more tracing of pregnant clients whose screening information generated a flag. If the form does not display because the person has not yet been referred, you might want to now contact the testing site to find out why that pregnant client that was reactive at their site has not been referred or sent for any intervention yet, regardless of the confirmatory results. So from reactive for pregnancy, flags are triggered. So if you get a call from PMTCT coordinator to